Today we're gonna talk about hyperthyroidism. Hyperthyroidism, also known as overactive thyroid and hyperthyroidism, is the condition that occurs due to excessive production of thyroid hormone by the thyroid gland. Thyrotoxicosis is the condition that occurs due to excessive thyroid hormone of any cause and therefore includes hyperthyroidism. Some, however, use the terms interchangeably. Signs and symptoms vary between people and may include irritability, muscle weakness, sleeping problems, a fast heartbeat, poor tolerance of heat, diarrhea, enlargement of the thyroid, and weight loss. Symptoms are typically less in the old and during pregnancy. An uncommon complication is thyroid storm, in which an event such as an infection results in worsening symptoms such as confusion and a high temperature and often results in death. The opposite is hypothyroidism when the thyroid gland does not make enough thyroid hormone. Graves' disease is the cause of about 50 to 80% of cases of hyperthyroidism in the United States. Other causes include multinodular goiter, toxic adenoma, inflammation of the thyroid, eating too much iodine, and too much synthetic thyroid hormone. A less common cause is a pituitary adenoma. The diagnosis may be suspected based on signs and symptoms and then confirmed with blood tests. Typically, blood tests show a low thyroid-stimulating hormone (TSH) and a raised T3 or T4. Radioiodine uptake by the thyroid scan, and TSI antibodies may help determine the cause. Treatment depends partly on the cause and severity of the disease. There are three main treatment options: radioiodine therapy, medications, and thyroid surgery. Radioiodine therapy involves taking iodine 131 by mouth, which is then concentrated in and destroys the thyroid over weeks to months. The resulting hypothyroidism is treated with the synthetic thyroid hormone. Medications such as beta blockers may control the symptoms, and anti-thyroid medications such as metimazole may temporarily help people while other treatments are having effect. Surgery to remove the thyroid is another option. This may be used in those with very large thyroids or when cancer is a concern. In the United States, hyperthyroidism affects about 1 to 2% of the population. It occurs between 2 and 10 times more often in women. Onset is commonly between 20 and 50 years of age. Overall, the disease is more common in those over the age of 60. Signs and symptoms. Hyperthyroidism may be asymptomatic or present with significant symptoms. Some of the symptoms of hyperthyroidism include nervousness, irritability, increased perspiration, heart racing, hand tremors, anxiety, difficulty sleeping, thinning of the skin, fine brittle hair, and muscular weakness, especially in the upper arms and thighs. More frequent bowel movements may occur, and diarrhea is common. Weight loss, sometimes significant, may occur despite a good appetite, though 10% of people with a hyperactive thyroid experience weight gain. Vomiting may occur, and for women, menstrual flow may lighten and menstrual periods may occur less often or with longer cycles than usual. Thyroid hormone is critical to normal functions of cells. In excess, it both overstimulates metabolism and exacerbates the effect of the sympathetic nervous system, causing speeding up of various body systems and symptoms resembling an overdose of epinephrine adrenaline. These include fast heartbeats and symptoms of palpitations, nervous system tremor such as of the hands and anxiety symptoms, digestive system digestive system hypermotility, unintended weight loss, and in lipid panel blood tests, a lower and sometimes unusually low serum cholesterol. Major clinical signs include weight loss, often accompanied by an increased appetite, anxiety, intolerance to heat, hair loss, especially of the outer third of the eyebrows, muscle aches, weakness, fatigue, hyperactivity, irritability, high blood sugar, excessive urination, excessive thirst, delirium, tremor, peritibial myxedema, especially in Graves' disease, emotional lability, and sweating. Panic attacks and inability to concentrate, memory problems may also occur. Psychosis and paranoia are common during thyroid storm and are rare with milder hyperthyroidism. Many persons will experience complete remission of symptoms 1 to 2 months after an euthyroid state is obtained, with a marked reduction in anxiety and sense of exhaustion, irritability, and depression. Some individuals may have an increased rate of anxiety or persistence of affective and cognitive symptoms for several months, up to 10 years after an euthyroid state is established. In addition, those with hyperthyroidism may present with a variety of physical symptoms such as palpitations and abnormal heart rhythm. Examples, the notable ones being atrial fibrillation, shortness of breath as in dyspnea, loss of libido, amenorrhea, nausea, vomiting, diarrhea, gynecomastia, and feminization. Long-term untreated hyperthyroidism can lead to osteoporosis. These classical symptoms may not be present often in the elderly. Neurological manifestations can include tremors, chorea, and myopathy, and in some susceptible individuals, in particular of Asian descent, periodic paralysis. An association between thyroid disease and myasthenia gravis has been recognized. The thyroid disease in this condition is autoimmune in nature, and approximately 5% of patients with myasthenia gravis also have hyperthyroidism. Myasthenia gravis rarely improves after thyroid treatment, and the relationship between the two entities is not well understood. In Graves' disease, ophthalmopathy may cause the eyes to look enlarged because the eye muscles swell and push the eye forward. Sometimes one or both eyes may bulge. Some have swelling of the front of the neck from an enlarged thyroid gland, that's to say, goiter. Minor ocular eye signs, which may be present in any type of hyperthyroidism, are eyelid retraction that causes the patient to stare, extraocular muscle weakness, and lid lag. In hyperthyroid stare, Dalrymple sign, the eyelids are retracted upward more than normal. The normal position is at the superior corneoscleral limbus, where the white of the eye begins at the upper border of the iris. When the patient tracks an object downwards with their eyes, the eyelid fails to follow the downward moving iris, and the same type of upper globe exposure which is seen with the lid retraction occurs temporarily. These signs disappear when the treatment of the hyperthyroidism is completed. Neither of these ocular signs should be confused with the exophthalmos, which is the protrusion of the eyeball, which occurs specifically and uniquely in hypothyroidism caused by Graves' disease. Note that not all exophthalmos is caused by Graves' disease, but when present with hyperthyroidism is diagnostic of Graves' disease. This forward protrusion of the eyes is due to immune-mediated inflammation in the retroorbital eye socket fat. Exophthalmos, when present, may exacerbate hyperthyroid lid lag and stare. Thyroid storm. Thyroid storm is a severe form of thyrotoxicosis characterized by rapid and often irregular heartbeat, high temperature, vomiting, diarrhea, and mental agitation. Symptoms may be unusual in the young, old, or pregnant. It's a medical emergency and requires hospital care to control the symptoms rapidly. Even with treatment, death occurs in 20 to 50%. Hypothyroidism. Hyperthyroidism due to certain types of thyroiditis can eventually lead to hypothyroidism, which is a lack of thyroid hormone, as the thyroid gland is damaged. Also, radioiodine treatment of Graves' disease often eventually leads to hypothyroidism. Such hypothyroidism may be treated by regular thyroid hormone testing and oral thyroid hormone supplementation. Subclinical hyperthyroidism. In overt primary hyperthyroidism, TSH levels are low and T4 and T3 levels are high. In subclinical hyperthyroidism, it's a milder form of hyperthyroidism characterized by low or undetectable serum TSH level, but with a normal serum-free thyroxine level. Although the evidence for doing so is not definitive, treatment of elderly persons having subclinical hyperthyroidism could reduce the incidence of atrial fibrillation. There is also an increased risk of bone fracture by 42% in people with subclinical hyperthyroidism. There is insufficient evidence to say whether treatment with anti-thyroid medications would reduce that risk. Diagnosis of hyperthyroidism. Measuring the level of thyroid-stimulating hormone produced by the pituitary gland, which is in turn also regulated by the hypothalamus TSH-releasing hormone in the blood, is typically the initial test for suspected hyperthyroidism. A low TSH level typically indicates that the pituitary gland is being inhibited or instructed by the brain to cut back on stimulating the thyroid gland. Having sensed increased levels of T4 and/or T3 in the blood. In rare circumstances, a low TSH indicates primary failure of the pituitary or temporary inhibition of the pituitary due to another illness, as euthyroid sick syndrome, and so checking the T4 and T3 is still clinically useful. Measuring specific antibodies such as anti-TSH receptor antibodies in Graves' disease or anti-thyroid peroxidase in Hashimoto's thyroiditis, a common cause of hypothyroidism, may also contribute to the diagnosis. The diagnosis of hyperthyroidism is confirmed by blood tests that show a decreased thyroid stimulating hormone level and elevated T4 and T3 levels. TSH is a hormone made by the pituitary gland in the brain that tells the thyroid gland how much hormone to make. Where there is too much thyroid hormone, the TSH will be low. A radioactive iodine uptake test and thyroid scan together characterizes or enables radiologists and doctors to determine the cause of hyperthyroidism. The uptake test uses radioactive iodine injected or taken orally on an empty stomach to measure the amount of iodine absorbed by the thyroid gland. Persons with hyperthyroidism absorb much more iodine than healthy persons, which includes the radioactive iodine, which is easy to measure. A thyroid scan producing images is typically conducted in connection with the uptake test to allow visual examination of the over-functioning gland. Thyroid Cintigraphy is a useful test to characterize and distinguish between the causes of hyperthyroidism and this entity from thyroiditis. This test procedure typically involves two tests performed in connection with each other, an iodine uptake test and a scan imaging with a gamma camera. The uptake test involves administering a dose of radioactive iodine, radioiodine, traditionally iodine 131, and more recently iodine 123. Iodine 123 may be the preferred radionuclide in some clinics due to its more favorable radiation dosimetry. That's to say, less radiation dose to the patient per unit administered radioactivity, and a gamma photon energy more amenable to imaging with the gamma camera. For the imaging scan, iodine 123 is considered an almost ideal isotope of iodine for imaging thyroid tissue and thyroid cancer metastases. Typical administration involves a pill or liquid containing sodium iodide taken orally, which contains a small amount of iodine 131, amounting to perhaps less than a grain of salt. A 2-hour fast of no food prior to and for 1 hour after ingesting the pill is required. This is low dose of radioiodine, typically tolerated by the individuals otherwise allergic to iodine. Larger doses of iodine, such as used in CT scan and intravenous polygram, some patients are unable to tolerate the contrast mediums containing large doses of iodine, and similar imaging and diagnostic procedures. Excess radioiodine that does not get absorbed into the thyroid gland is eliminated by the body in urine. Some patients may experience a slight allergic reaction to the diagnostic radioiodine and may be given an antihistaminic. Treatment of hyperthyroidism. Anti-thyroid drugs. Thyrostatics or anti-thyroid drugs are drugs that inhibit the production of thyroid hormones such as carbimazole and methimazole and propylthiouracil. Thyrostatics are believed to work by inhibiting the iodination of thyroglobulin by thyroperoxidase, and thus the formation of tetraiodothyronine T4. Propylthiouracil also works outside the thyroid gland, preventing conversion of mostly inactive T4 to the active form T3. Because thyroid tissue usually contains a substantial reserve of thyroid hormone, thyrostatics can take weeks to become effective, and the dose often needs to be carefully titrated over a period of months with regular doctor visits and blood tests to monitor the results. Beta blockers. Many of the common symptoms of hyperthyroidism, such as palpitations, trembling, and anxiety, are mediated by increase in beta-adrenergic receptors on cell surfaces. Beta blockers, typically used to treat high blood pressure, are a class of drugs that offset this effect, reducing rapid pulse associated with the sensation of palpitations and decreasing tremor and anxiety. Thus, a patient suffering from hyperthyroidism can often obtain immediate temporary relief until the hyperthyroidism can be characterized with the radioiodine test noted and more permanent treatment take place. Note that these drugs do not treat hyperthyroidism or any of its long-term effects if left untreated, but rather they treat or reduce only symptoms of the condition. Some minimal effect on thyroid hormone production, however, also comes with the propranolol, which has two roles in the treatment of hyperthyroidism, determined by the different isomers of propranolol. L-propranolol causes beta blockade, thus treating the symptoms associated with hyperthyroidism, such as tremor, palpitation, anxiety, and heat intolerance. D-propranolol inhibits the thyroxine deiodinase, thereby blocking the conversion of T4 to D3, providing some, though minimal, therapeutic effect. Other beta blockers are used to treat only the symptoms associated with hyperthyroidism. Propranolol and metoprolol are most frequently used to augment treatment for hyperthyroid patients. Other lines of therapy include surgery as total thyroidectomy and also radioiodine in the form of radioisotope therapy. Thank you.